So, good afternoon to all of you. Yeah, so it's recording. So, this is a session that is not usually present on our roster, but I just felt that I should make a presentation based on the question that was asked by one of my students a few days back. So he had certain discrepancies regarding the susceptibility of macrolides in enterococcus. So he asked me, Dr. Manish Mishra, he was my former student, he pointed out that there are erythromycin breakpoints which are existing in CLSI. If you see table 2D, the breakpoints are there. So, but at the same time, he mentioned that in one of the books on AMSP, it is documented as intrinsically resistant. So there was a discrepancy as to what to consider as correct. So I told him follow CLSI. All right, but then normally books will do some research before they publish it and they do the proofreading. So there must be some substance in there with the claim made in the book. So because that book said the enterococcus is intrinsically resistant, so let us try and find out the truth. What is the reason? So that is the reason why I took this presentation, because I found that there is some discrepancy, and all the questions which are asked or whenever there is a sense of inquiry among the students, it always incites a sense of inquisitiveness and to search the truth. So this is the main article that I'll be referring to. This is entire presentation is going to be centric to this article. So CMI, Clinical Microbiology Infection, it published an article in 2022 or 23, I think it was. So it was the expected phenotypes and expert rules are important complements to AST. Now this is, if you can see that name Gunnar Carl Meter, so that means it is definitely, and John Turnage, so definitely it's from the UK or from the Europe, and it is essentially around EUCAST only. So why I wanted to see this, because while I was searching for that answer, I came across this paper and I realized how things are different between EUCAST and CLSI. Not just the breakpoint, the entire approach is quite different, and why we need to understand these differences. So how I've made this presentation is that first I found this article, I read the main article again and again. Then I fed this article on Notebook LM to make this PPT based on AI. And then I integrated the related topics and issues as an additional information to this presentation. So what I feel is that you should first read the articles. Yes, we do have AI and we must use AI. I'm not denying that. But it is always good to read the article and then put that article in the software, AI software, and then generate a presentation, and then always complement and supplement it with additional information whenever and wherever possible. So just blindly trusting AI is not enough, because AI will not extract all the information, because essentially it does not possess any consciousness. So what I would like to learn from this presentation is that what are expected phenotypes and what is intrinsic resistance. So expected phenotypes is a term that is used by EUCAST, and the intrinsic resistance term is used by CLSI, specifically in Appendix B of the M100 document that we search for every year. And we search for every year because we think that it is paid, so whatever is paid has got more value, so we tend to stick more towards CLSI. Whereas if we see EUCAST, it is all available online, it is all free of cost, and it's very, very scientific. So we should know what are the differences between expert rules of EUCAST and what is the meaning of the comments of M100, because M100 or CLSI per se does not have a separate PDF for availability of expert rules separately. They are integrated in the tables 2, 3 and 1 also of your M100 document. Then among CLSI only, what's the difference between the expert rules and the expected phenotypes? All right. Why is because this is important specifically for the expert rules, because they've got clinical implications. And expected phenotypes again are of two types. So again, what we see in CLSI is only one appendix, that is intrinsic resistance. We don't talk about intrinsic susceptibilities, whereas EUCAST clearly states what is expected resistance and what is expected susceptibility. And if you see, there is a very clarity towards the approach of EUCAST as compared to CLSI, and which personally I feel that yes, you might be using CLSI breakpoints, but the expert rules and the expected phenotypes can be followed from EUCAST also. So what is the difference between the expected phenotypes and your expert rules? What is the difference? What it really means? Are they both the same things, or they are overlapping, or you use one for the implementation of the other? So if you see, the main difference between CLSI and EUCAST is that it talks about intrinsic resistance in the Appendix B of the M100 document. There are no separate tables for resistant phenotypes or susceptible phenotypes. So there is no separate appendix for susceptible in CLSI. There are no separate expert rules or extrapolation rules or surrogate rules. They are all integrated in the tables only. So if you see tables 2 specifically, where they talk about the breakpoints, in those the comments are integrated in those tables only. Whereas you see EUCAST, you have separate tables for resistance, separate table for susceptible. They are all available free of cost and you can access them anywhere. Then there are separate expert rules guides, and you'll see separate expert rules for Staphylococcus, separate for Acinetobacter. Where the expert rules are not given, they have a separate guidance commentary is there, and there are also guidelines which tell you if there are no breakpoints available, then what are you supposed to do, right? So that is a very, very mature approach of EUCAST, because they have their own labs and they generate their own epidemiological cutoff data. Now we all do the reporting on the AST of AST, and we know that the raw AST data is not a clinical report. All right, we just cannot implement everything that we see on the plate, on the bench, totally into a clinical report. There is a huge gap, and why that gap is because we first need to establish the biological validation. That means it is clinically whether this particular bug that you isolate, let's say you isolate Klebsiella from a tracheal aspirate, is it really clinically and diagnostically significant? Which is why we are strongly implementing the diagnostic stewardship protocols that look at the gram stain very, 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 very carefully, look at the specimen very, very carefully, look at how has it been collected, how it's been transported. So all these factors are very critical for the biological validation to understand whether it is really a true pathogen or not. Then we have got the therapeutic guardrails, so which guard us not to start prescribing any antibiotic on the AST report and hold back certain things which are not required for the patient. So has the antibiotic has it been reported wisely or not? So this is the antimicrobial stewardship component. Of course we do the HIC component. So until unless these things are not there, there will not be a proper actionable patient report with a verified ID, adjusted susceptibilities and clinical comments. So what we do, the customization that we do in our lab by myself or Dr. Deb or Dr. Lonika or Dr. Nidhima, that is what the actual, that we have to filter out a lot of things from the raw data and then only put up the final AST report. Now the definitive diagnostic matrix means CLSI I told you has got only appendix B, which is intrinsic resistance, whereas EUCAST has got both expected resistance and expected susceptibilities. Now what are the expected phenotypes and what are the expert rules? What are the major difference? So these parameters, they are overlapping essentially, but then I'll just try to distinguish them among each other. First of all, the primary purpose of the expected phenotype is the bacterial validation. So if you know that if this is definitely group A streptococcus, it will definitely be susceptible to penicillin. It cannot be resistant to penicillin. So that is the validation. So first we have to be dead sure about the identification of the bug, which is why it is not a bad idea if your MALDI is not giving you correct result, go in both for your phenotypic identification, your serological identification, and try to understand if this is the particular bug and this is the MIC value, then what are the biological constants? So that means if you know that this is group A streptococcus, the MIC values for penicillin are going to be 0.0625. It will not be 1, it will not be 0.5, it will be very, very, very low. Alright. then you have to confirm or reject the presumptive ID. Same if I give you the example of group A streptococcus, if it is coming to be penicillin susceptible, either your disc is not working or the QC is correct, that means your strainous identification is wrong. So that is why you should expect what is the phenotype expectation. It's primarily based around your in vitro microbiological data. So it is totally in vitro and a laboratory based technique, whereas when you extrapolate it towards the clinical side, they become your expert rules. Like for example, if you say that group A streptococcus, this is group A streptococcus, it has to be susceptible to penicillin, that means I can give penicillin or ampicillin to the patient. So it gives you the advice for antimicrobial therapy. So expected phenotype forms the basis for you to give a treatment protocol for the patient. So clinical scenarios and risk for treatment failure, again the same thing. If you know that this is definitely an ESBL plus AMC producer or a purely an AMC producer, you will not give the patient imipenem, you will not give the patient any augmentin, you will not give the patient any third generation cephalosporin. So you have to be again dead sure about the identification, because that will reflect on the expert rules. So once you say that this is cefoxitin resistant enterobacter cloacae, the clinical scenario and the risk is that I will not give any augmentin, I will not give any third generation cephalosporin, I will not give any carbapenem. I should avoid these, and treatment of choice, it's known, it has to be cefepime, correct? So same thing, so you have to modify the report or add these clinical comments. So this is just the in vitro microbiological data, where this is the clinical extrapolation of your microbiological data. Now the laboratory check. Now how expected phenotypes will help you in diagnosing or notifying that your quality control is perfect. So that means your MALDI says it is group A streptococcus. Yes, it is group A streptococcus. You know it, and it's penicillin resistant. That means your disc is not working. So that is a reflection on the quality control. So expected phenotype, they serve as biological validation tools. They answer a fundamental question: does this susceptibility result make sense for this specific organism? So if your MALDI says enterobacter cloacae, it has to be resistant to cefoxitin. If it is susceptible, now I'm giving the opposite example. If it is susceptible to cefoxitin, then please re-identify your bug. So that is the critical insight, that if a test contradicts an expected phenotype, it argues against the presumptive identification of the bacteria itself. So it is the inherent intrinsic nature of group A streptococcus to be susceptible to penicillin. It is the natural intrinsic nature of enterobacter cloacae to be resistant to cefoxitin. Alright, so that identification or the test must be reviewed if there is discrepancy. So that is what, so now if you see this example, very interesting example came just a couple of months back. We had a penicillin susceptible Staph aureus. It is rare, but hyper susceptible penicillin susceptible Staph aureus is rare. So if you see this photograph, the zone diameters were in the susceptible breakpoint range. In fact, they were beyond that range. So you don't see such huge penicillin zones for a penicillin susceptible Staph aureus. Maybe around 35 millimeters with a nice beach, all right, but not 65 to 70 millimeters. It is too big. It is too big for a penicillin susceptible Staph aureus. So what is the ultimate hypothesis? That is the vendor supplying the penicillin disc with increased drug concentration on the disc. Now why I am saying is that there are certain vendors who are, let's say for example, located in Mumbai. So he is making a disc in Mumbai which has to travel maximum till Pune. So that's barely a 1 hour drive. But if I have to send to Vijayawada, so that means there will be degradation. So probably their lot numbers are having different concentration of penicillin depending on how far they are supposed to ship that consignment. Alright, so you have to be careful about this also. So huge zones does not mean that it is very nice. Oh, nice zone. That could be that your penicillin zone size or your penicillin concentration would be much higher. So if we maybe someday if we go in for an HPLC, maybe we can see the actual concentration. It is not 10, it could be 20, it could be 15, we don't know. But it seems to be higher as compared to the usual breakpoints. Now the thresholds for biological expectation. Now when I use the term expected resistant and expected susceptible, so is this expected resistant synonymous with the intrinsic resistant of CLSI? So had this been So what the changes were made a couple of years back was gentamicin breakpoints were removed from Pseudomonas. All right, but at the same time, gentamicin has not been included in the Appendix B of M100 of CLSI. That means they have removed the breakpoints, but they are not considering it at intrinsic resistant. What could be that reason? Let us try to see those things. So when we say 90%, why we have kept the threshold of 90% over here? So 90% of the particular strains, they will have resistance. The MIC's value will be so high that it cannot, that concentration cannot be achieved by the usual doses. All right. So 90% threshold has been kept for expected resistant. The great majority of wild type isolates exhibiting the MIC values are so high that the agent should never be considered or tested for therapy. So you know that you cannot give nitrofurantoin for Proteus, you cannot give colistin for Proteus. All right, so it is. But if you see the other one, expected susceptible, 99% threshold has been kept, not 90%. The resistance is virtually unknown. Detection of resistance strongly indicates an identification error or a testing failure. So is your, let's again go back to group A streptococcus. If it is group A streptococcus and penicillin resistant, so it's either not group A or your penicillin is not working. Now the question is that why 90% for resistant and why 99% for susceptible? Because expected susceptible reflects your treatment outcomes. Let's see again this slide, what does it really mean? So phenotype determines what can be given for treatment and what cannot be given for treatment. So if you know that if it is a group A streptococcus, it will never be resistant to penicillins. It will always be susceptible only. So the threshold has been kept as 99% because you are dead sure that this is group A streptococcus, it has to be susceptible to penicillin. So that is the level of, because in that case you will give penicillin to the patient. You can't have a margin of 10%. Like 10% strains might be resistant. No, you can't do that. You can't take that chance. So that is why it has been kept as 99% for the susceptible phenotypes and 90% for the resistant phenotypes. Now, again in the expected resistant, you see this Haemophilus influenzae versus linezolid. So over 90% population shows a higher MIC value. So this is the break point over here for linezolid, between 2 and 4. So if it is most of strains, they have got the MIC distribution much higher than the break point, the clinical cutoff. So that means more than 90% strains. So there is still a small population over here which can be treated. So that is probably those 10% which are there, which we say. So why? Again, this is a natural resistance. Now if I tell you that we have got penicillin susceptible staph aureus, so immediately you will see, where is it? It is so rare to see because it is all acquired resistance. So this is a difference between natural resistance and acquired resistance. Now there will be a stage where you will see, hardly you will see probably, maybe many of the institutes might be having 85-95% ESBL AMC co-producers. So acquired resistance is so high that you don't believe that it could be susceptible. Like when initially in our institute we started having, that is why I was so finicky about saving the pan susceptible isolates, because they are the ones that will help us to make the epidemiological cutoff values. Whereas we have the acquired resistance so high that you expect it to be resistant. You will not expect to give MSSA is fine, but a penicillin susceptible staph aureus is very rare. All right, so that is why this is something very different. So acquired resistance is so high that you don't expect. So expected resistance is intrinsic or natural, or it can be acquired, and it's that acquired becomes so common that you can't, and maybe over the centuries or over the, maybe you can say epochs or decades, maybe at some time Pseudomonas aeruginosa could have been susceptible to ampicillin, but somehow it might have acquired the strain, and slowly that the gene became intrinsic and inherent to the chromosome of Pseudomonas aeruginosa, that AMC beta lactamase became the natural property of Pseudomonas aeruginosa. Similarly, maybe a few decades or maybe a few centuries down the line, you may not even see any strain of penicillin susceptible staph aureus. You stop testing for the oxacillin or penicillin and all those things. You stop testing. Like we don't test for Proteus, nitrofurantoin, we don't report, so like that only I'm saying. Similarly, Now there are therapeutic guardrails. All right, at the bedside, the therapeutic guardrail is that we don't send the raw data immediately to the wards. These expert rules. Now, expert rules, what I'm saying is that they will take the information from the expected phenotypes and the expected resistances, and then accordingly we have to filter it out. So even if I see imipenem susceptibility in Enterobacter cloacae, I will not report it. So that is the guardrail. So you might think, what is susceptible? Report it. No. This is the guardrail that you have to realize that if this is Enterobacter cloacae, it is AMC producer, it will definitely create resistance the moment you give a inducer of the AMC beta lactamases like your imipenem and your augmentins and moxiclav and all those things. So the expert rule shifts the focus from the laboratory validation to the patient outcome, and they take the verified identifications and test results to deduce actionable recommendations. So what is actually to be given? So you have to filter out the raw data, and the primary function of the expert rules is to indicate when to avoid antimicrobials that are likely to result in treatment failure. So we have, I've shown you multiple times the cases that we have reported that after 1 or 2 doses of augmentin and moxiclav, the strain became resistant, and it even got so induced that it even became resistant to your carbapenem. That is why we won't report these drugs for the AMC producers, and which is why this identification is important. And those things which are not mentioned in the books, not mentioned in the guidelines, we have put it up in our labs multiple times. I must have told you that what are the things that you're supposed to see. Now CLSI says you're not supposed to put more than 6 discs on a 90 mm plate. At the same time, they also say that the distance between the edge to edge should be 25 millimeters. What I have practiced for the many years is that you start putting imipenem in the center as an inducer and surround it and ensure that those distances among the disc to disc, the edge to edge is 25 millimeters. Then that's the time you see, because this is something which nobody tells you. No guideline, nobody will tell you to place an imipenem disc in the center and surrounded by the various BL-BLI combinations, because that will also show you the expected phenotype. That will reveal what is the true nature of the bacteria by when you put an inducer disc like imipenem in the center, which is why I'm telling you again and again that other than the expected phenotype, in fact, EUCAST in 2017, they had given a guideline on the detection of AMC beta lactamases, but they required certain special plates to be put up. But in this case, what we are doing on a daily basis, we can detect AMC ESBLs in the routine plates also. Now, the architecture, how the expert rule gets deciphered. So we have the organism plus the agent. The expression, is it true? Now we know that E. coli possesses the AMC gene. So again, this is something which is document we were discussing yesterday only with my co-faculty, that E. coli does have an AMC gene, but it does not have the inducer mechanism. This is what has been known by the Western literature. But what do we see in our labs? They are all mildly confirmed E. coli, and they're showing beautiful inductions with imipenem. So there is an inducing mechanism. So that's why I said this is not happening now anymore. We don't have the E. coli. So what they say is that presence of the gene does not mean the expression of the gene. That's correct. But what we are seeing over here is that AMC is being produced by E. coli, and AMC is being expressed by E. coli, and AMC is showing the D-zoning the moment we put up imipenem disc in the center. So when we say that, note on the mechanism that expert rules rely only on the phenotypic test and clinical breakpoints. They do not rely solely on molecular detection. It is true, but again I'm saying what you see on the plate will depend on how you're placing the discs, how you're inducing the bug to create or to express that resistance. All right, so the expert logic, we see it in practice. For example, this is what we call as surrogate markers. Now surrogate markers is something that is given in great detail in EUCAST, but normally maybe sporadically here and there it is mentioned in the CLSI tables in under table 2. Like for example, if it is E. coli, the indicator strain is ampicillin. Now this surrogate marker is given in thorough detail. What should be the fluoroquinolone resistance surrogate marker for E. coli? What should be the fluoroquinolone resistance marker for Staph aureus? So all these are given the expert rules separately in your EUCAST. So much of detailing is not mentioned in your CLSI. So this is something that we commonly do, that if it is susceptible, if it is resistant to ampicillin, then it will be resistant to penicillin also, probably resistant to piperacillin also. So regardless of the in vitro results, so we have to extrapolate to that, extrapolation or use of surrogate markers, and that is the reason why over the years through observation we realized to change the surrogate markers also. So the latest expert rules and the you can say this the surrogate markers, it was released on 10th of July 2026 by EUCAST. You can check it on the website. I'll share it with you also. So surrogate markers, and you should know what surrogate markers to be used for which bug and what is the level of evidence. So there will be different levels of evidence, like for example there is grade A, grade B and grade C. This is something not given again in CLSI, because in 2010 they had changed that we will now remove the extrapolation that if an E. coli is resistant to cefotaxime, then it is resistant to all the third generation beta lactam drugs. And that is why CLSI used to think that what are the best agents for detection of your ESBLs. So you use cefotaxime, ceftriaxone, cefotaxime, astronam, and one more they were using, 5 they were using. So later on they realized that this is not the correct evidence, because the ESBL is substrate specific. So if it is a CTX-M, it will attack cefotaxime, ceftriaxone, it may not affect ceftazidime. But at the same time, they are not sure whether they can really use ceftazidime as a treatment option or not, which is why they had a very guarded opinion. So that's probably somewhere grade B or grade C kind of evidence, but there is no specific conclusion by CLSI what to be used and what not to be used. Now they say that it is to be used primarily for epidemiological purposes, right, for hospital infection control purposes. Now there are multiple tables both in EUCAST and in CLSI. They put a dash. That means there is nothing over there. There is no intrinsic resistance. There is no IE. IE is increased exposure. So what we call it as SDD in CLSI is commonly interpreted as IE in your EUCAST also. So if you see the EUCAST treatment protocols, you will find that in EUCAST there are 2 tables. One is the table that is for the usual doses and the increased doses. So there are 2 tables are there. But then there are a lot of dashes and missing areas. And what does the dash means? The dash means do not use or do not test that particular bug, the particular antibiotic for that particular bug. But why the dash is there will all depend whether it is driven by a biological phenotype or a therapeutic rule. So I'll just detail that about you. So what the expected phenotypes and expert rules do in the breakpoint tables. So if you see this table, now this is where the question arose what Manish had asked me initially. Now this probably he would not have seen this, even I had not seen this. So again I'm saying that every question arises inquisitiveness. So this is the inter-EUCAST table of EUCAST and this is the inter-EUCAST table of CLSI. This is table 2D. So if you see very carefully in table 2D of inter-EUCAST, you'll see there are breakpoints are available for erythromycin. Right? CLSI has got erythromycin breakpoint for inter-EUCAST, whereas the same point time there's a dash over here. Erythromycin, in fact all macrolides, there are no breakpoints, their dash is there. That ATU means area of technical uncertainty. Alright. So EUCAST has got no breakpoints for inter-EUCAST, there is just a simple dash given over there. And what does that dash really mean? That dash could be either it is expected resistance or there are no breakpoints. So EUCAST might be having the epidemiological cutoffs for erythromycin and macrolides, but does not have clinical cutoffs like many of the strains in case of CLSI also. And the third is to discourage the use of that antibiotic for that organism. So despite the availability of the clinical cutoffs, there is no, the epidemiological cutoffs, there are no clinical cutoffs because it has been found that clinically it may not be useful. One typical example is that we don't use first generation, second generation cephalosporin for Salmonella typhi. We don't use amino glycoside for Salmonella typhi because that, if you remember that point is given in a CLSI that despite showing in vitro susceptibility, they should not be used clinically because there can be in vivo failure, right? So that is the meaning of this thing. So this is very typical for many of the bugs. I'll show you another example of Acinetobacter and ceftazidime also. But this dash in CLSI means there are no breakpoints. All right. Now, if you see again, now these are the breakpoint tables. All right, the breakpoint tables. expert rules and expected phenotypes. So some of the notes are mentioned here, but they have been more explicitly detailed separately in these tables. There are two separate tables. One I think is an 8-page document for resistance, and one is a 5-page document for the susceptibility. So if you see the expected resistant phenotypes, so you'll see over here enterococcus as per EUCAST is intrinsically resistant to macrolides. So that dash is not because of non-availability of breakpoints. That dash is mainly meant for the intrinsic resistance. So that is why the dash in EUCAST means do not use, do not test. So that is the confusion that arises, that the book probably mentions EUCAST, but it has not been referenced over there, and that is the confusion that he said that I am looking at CLSI shows breakpoints, that book shows resistance. So try and look over both the aspects of the coin. Now if you just decode the breakpoint dash, so I said there are mainly two parts. Expected phenotype, the dash signifies the organism is intrinsically and biologically expected to be resistant. And the implicit expert rule is that the dash signifies clinical danger despite a wild type distribution that may test as susceptible but highly discouraged, which is the reason why many of the breakpoints have been removed from Burkholderia cepacia, because there might be absence of the clinical breakpoints, but there might be ECOF breakpoints might still exist. So the golden rule is that when you don't have any interpretive criteria for bugs like Burkholderia cepacia, in that case you are supposed to perform the MICs. You cannot rely on disc. You perform the MICs. If the MIC value is equal to or less than your ECOF values, that is the only time when you can interpret it as susceptible, and you can not even write down susceptible. You can just say that the clinical strain has got the MIC values or the wild type strain, and hence this therapy may be attempted in this patient. So we have to give a very guarded comment when we don't have any breakpoint MIC values. So if you see this curve again, this is the now Acinetobacter baumannii. If you see M100 document, so there are 3 strains which are used, that is ATCC strains, E. coli, Staphylococcus and Pseudomonas. All right. So where we see the wild type cutoffs for the genetically characterized strains, which we call as ATCC strains. So what are quality control that we see, the QCs, it's against the genetically characterized wild type strains, the ATCC 25922, 27853 and 29213, 29533, also their numbers, they are all ATC strains which are genetically characterized. Now this is the MIC distribution of Acinetobacter baumannii against ciftaridime, and they have taken the cutoff of Pseudomonas aeruginosa because this is something it is nil fermenter, so they have chosen another nil fermenter breakpoints to decipher what this should look like. Now this is the same thing which has happened in your Cefta IV Astronam broth disc illusion test that we do for Enterobacillus, and the same has been extrapolated for your this one, Stenotrophomonas maltophilia, and this is also given in a CLSI, but there are no breakpoints for Astronam over there. So they are using the breakpoints of Pseudomonas over there. So this is something that we really just recently published as a letter to the editor, just showing that why it has been used like, because there are no wild type cutoffs. So in this case you see that more than 10% of the isolates, they are falling in the susceptible ECOF values. Susceptible, actually ECOF, you don't call it as susceptible because you're not using those values for treatment protocols. So if you see that more than 10% strains are on the left side, they are susceptible, but they are not giving ciftaridime because there might be in vivo failure. So despite having in vitro susceptibility, there might be in vitro failure. Now there is a theory why they are not combining the breakpoint tables of EUCAST along with the expert rules. Some comments are there, but then it becomes too hodgepodge. It becomes too tedious to put so many comments on the breakpoint table, because if you see the expert rules and the comments, you will find out that every organism has got separate expert rules. All right. So expert rules are made as per organisms and the antibiotic and not vice versa. All right. So if you see that the diagnostic workflow that we need to follow is that we need to find, we have to be heavily rely on the gram strain, which is why for the residents I am very finicky about what is the gram strain finding should be mentioned, it should be documented, and even if it does not correlate with the plate findings, that's still okay. But you exactly write down what you see very carefully, because what you see and what is the plate might have discrepancies in how the specimen has been collected. So you have to see whether there is match or no match, whether you have to send a repeat, you ask for a repeat sample, you have to look at the expected phenotypes, do the correct identification, put up the expert rules, and then only give the final actionable report. So the final take is that you should know what are the expected phenotypes validated by science in the laboratory. So if it is, that is why your identification has to be very, very accurate. So you have to tell the clinicians also that the ID of the bug is very, very important, especially the PDCC should know this, that not to start any therapy for gram negatives, any therapy for gram positive, because those what we suspect for gram positive may not be the correct drug for the gram positive, and vice versa, because we should know the exact ID of the bug and how to correlate that the expected phenotypes into a clinical report. That is also very important, and that is where the faculty has to sit on the reports and do the filtering out. So there are cases where on the HUNET report is given as D test positive, but it is reported as CLINDA susceptible. So those filtering we have to do. So that mistakes can happen, because you might enter it as D test positive and CLINDA as 28. So HUNET may take it as S. So instead of that might get that may be given as therapy. So that is why we have to filter out and apply the expert rule guides at the bedside. All right. So that is the purpose of, just to show that why you should not take only one single guideline as the final authority. Go in for EUCAST expert rules, EUCAST expected phenotypes, EUCAST guidance documents, EUCAST breakpoint tables, EUCAST dosings. So all these things are separately given in the EUCAST. The only issue with is that they have to be little hunted. You have to search a lot on EUCAST and then take down and then use them as the guideline. You may take the breakpoints of CLSI, because that is the most common disk strength that we are using, but the expert rules and the expected phenotypes, they are all similar all across. So it is a little complicated, but then you have to apply all these things whenever and wherever possible. All right. Thank you.